think we're recording and ready to go. Thanks everybody for joining us today. We're happy to have you at Grand Rounds on this Monday, the 15th of November, and happy to have with us our special guest, Dr. Ouchi, who is duly boarded in internal medicine and emergency medicine, and with a career goal that I thought was really interesting around sort of taking the scope of emergency care, dealing with acute issues, and bringing in some of those internal medicine things that we do around patient-centered care, palliative care, geriatrics, all these things we like to bring to the world. And so, and he seems like the right person to do that. Duly trained, a number of impressive awards, including the Paul Beeson Emerging Leaders Career Development Award from the National Institutes of Aging, the Fulbright Scholar, Sojourn Scholar from Cambia Health Foundation, so many other things. We are delighted to have him with us. Dr. Ouchi, take it away.
Thank you so much for the kind introduction, Dr. Weissman, and thank you so much for having me, Dr. Mitaka. Let me just start sharing my slides, and let's see. Does that show up okay? Okay, great. Thank you. So thank you so much. I'm really delighted to be here. My name is Ouchi, and I'm an emergency physician predominantly at Brigham and Women's in Boston. And I also split my time between that and some home hospital work, and also advanced care planning research, which I will touch on as well today. And today I'll be talking about goals of care conversations for acutely ill older adults. And I will sort of explain how this is related to my career, as well as how it could be relevant for your practice, as well as your career trajectory as well. So I have no really disclosure for conflict of interest. I just received research funding from Cambia Health Foundation and National Institute on Aging. So the objectives for today are to really understand significance of acute care visits for patients with serious illness, especially for older adults, and define crisis communication and serious illness conversations, which I will define them so that you know what I'm talking about. And I hope to kind of talk a little bit about clinical and research approaches to solving these problems that you, I think, run into in your clinical career that I will try to define a little bit more. So here we go. Today, so outline number one is significance of acute care. Number two is types of conversations. Number three, I'll talk a little bit about my research. And I think that it is my clinical research, and you will find probably that you can use some of those components in your clinical practice as well. And I will also shift gears to talk more about your really more clinical aspects of how to lead code status conversations in best practice. So number one, why is acute care so important for older adults with serious illness? Well, the thing is, I trained at Long Island Jewish Medical Center, and this was my patient when I was a resident. He was in his late 60s with metastatic cancer, presenting to the emergency department with fever and back pain. What was notable about his visit was that was his 6th emergency department visit in the last 6 months. And every time he got either admitted or discharged, and he kept coming back with the same complaint. So we couldn't figure out why this was happening. And once palliative care team went to go speak with him, we realized that he knew that he was slowly dying, and he just could not control his symptoms at home. And that's why he kept coming. So he ended up going to home hospice from emergency department and died with his family. And on the left is Andrea, his daughter, who came to talk to us in emergency department, saying that was really important to articulate this, what he wanted at the time when things start going down. And this sort of began my career about how can I improve this from the acute care side. So when you look back on the literature, most older adults come to the emergency department in the last 6 months of life. And as the functions on the y-axis and times on the x-axis, the time when their function is start to decline is the time when acute care visits happen, sometimes and most of the time in emergency departments. And most of the time, patients don't die like this red line that's depicted here. And they have a chance to sort of get better a little bit and then get worse again until they reach death. And I really think that this is a teachable moment for these patients to start thinking about what's important to them as they get sicker. Now, emergency department visit or any acute care visit is really clinically significant for these folks. So if you look at older adults with different comorbidities like heart failure, 1 year mortality after an acute ED visit is fairly defined, and it gets worse as they get older, as you can imagine. And this is for the heart failure patients. This is for patients with COPD. This is for patients with different cancers, solid as well as liquid cancers, and coming into the emergency department. So the point here is that patients with serious illness like metastatic cancer or COPD, they have a defined sort of long-term mortality when they have an acute care visit, like an emergency department. And this is also for patients with cancer and cancer with pneumonia. They have a sort of a defined mortality after they visit the emergency department. So as you can see, the literature is clear that patients in these situations, when they have the acute care visit, the mortality is defined. So what are we doing about it? And I'm going to talk a little bit about what I mean by different types of goals of care conversations for seriously ill patients. So when I thought about this for acute care settings, when I'm sure many of you have seen this type of diagram before, where the time is going from left to right, and this is the time when someone's diagnosed with serious life-limiting illness, and this is the time that someone may die. Well, the type of care usually changes from preventative care to disease-modifying treatment to more palliative treatment. And the settings in which patients receive care predominantly changes too over time. And when I think about different types of conversations, I think that here, before people get sicker, that I think most people agree that is called advanced care planning, where you're trying to prepare for what may come ahead in the future and you haven't really had a serious problem yet. Well, as you probably know from your outpatient clinic experience, a lot of times this is sort of premature. Patients feel that they don't really understand why this is so important. And, if people do that with me, when I go to clinic as a patient, I feel the same way. Well, and when you come to the emergency department towards the end of life, well, I term that crisis communication, and I think that that's way too late. When I meet patients who are about to be intubated with hypoxic respiratory failure and metastatic solid tumor cancer, there's really no time or sort of emotional capacity to have a well-informed decision-making. And all the other times in between, when they're going in and out of inpatient to outpatient and getting more and more inpatient care and acute care visits, those are the time when we would call these conversations serious illness conversations, where they actually have a serious life-limiting illness that they're faced with and living with. And this is the time, I think, where people start to understand the value of articulating what's important to them, and letting people like their physicians and their family know about what's important to them becomes really important. So I'm going to touch on both of these things. So this one for research and this one for more of a clinical practice suggestions. So the differences between these two is that in serious illness conversations, patients are generally clinically stable. And we still talk about patients' values and preferences, yet there is really no decision-making necessary at that time. So think of a situation when you're taking care of someone with COPD exacerbation in a hospital and they're getting better. Well, they are getting more stable as you treat them. And you can talk about their values and preferences, but there is really no decision-making. And this seems like, on the other hand, crisis communication is that mostly patients are clinically unstable, and we still try to get to patients' values and preferences, yet this could be limited due to patient's illness severity. And unfortunately, urgent decision makings are necessary. So I'm sure you do these in rapid responses on the floor, because we do these in emergency department too. And I hope you can see the parallel between these two. And one would be easier and the other would be harder. So this is likely easier to study in sort of a controlled setting. And this is a little bit harder to study because it just happens spontaneously. And it's hard to consent people when they can't breathe. Like, would you like to enroll in a research study? Like, it's really difficult to do. So these are the two distinctions that I wanted to make. And I thought about what can we do to improve upon this, because we see this all day long in our clinical practices, both in emergency department and the hospital floors. So I thought about approaching serious illness conversations, how to improve that with my research, which I will talk about. And then crisis communication, I lean more towards teaching and sort of training clinicians to improve their communication skills. And I will touch on that as well. So I will talk a little bit about my research, and I hope things that I talk about in this research, I think are relevant to patients as well as clinicians who care for patients in acute care settings. And I hope you can do something similar to this in your clinical practice. So emergency physicians widely recognize that there's an opportunity to not delay palliative care involvement when patients could potentially benefit when they come to the hospital. And most of these patients, unfortunately, get admitted to the hospital and they fall on sort of your footsteps. And the knowledge gap is that there is really no feasible method to intervene in acute care settings, because we don't really know what might help and we don't really know how to do that either. And there are many different problems associated with that, like we have never met these patients before. And the potential solution I call brief negotiated intervention. And what that is it's based on motivational interviewing, and it uses clinicians' empathetic reflective listening to elicit patients' behavior change. And the behavior change that we're trying to target here is for patients to sort of be more engaged in their serious illness conversations. And this broadens patient skills and increase their confidence to take better control of their healthcare decisions that are to come. And hopefully it's effective in reducing whatever the future behavior that you want to avoid. And I'm going to briefly touch on alcohol and substance abuse, because that has been the area where there's most evidence. And I'll show you why this is relevant for our talk today. So I have sort of developed this based on prior interventions like this in emergency department. And for alcohol and substance abuse literature, these type of intervention has been done, and these are all in emergency medicine textbooks, because they have been shown in multiple randomized trials to improve patients' outcomes, like reducing unhealthy drinking. So I thought maybe I can do the same thing and try to empower patients so that they can take better control of their health. So the conceptual model for acute care facilitated serious illness conversation is that we identify the right patients. And what I mean by that is patients with life-limiting illness who come to the acute care settings like emergency department or inpatient settings. And then we do this patient empowerment with ED Goal. That's the name of my intervention. So that couples motivational interviewing. So it helps patients to kind of realize why this is important at this particular time in their illness, as well as going through some serious illness questions about their values. And then our hope is that this will lead to more engagement in serious illness conversation by the patient. So this is similar to patient activation. And then hopefully that will lead to more serious illness conversations in an outpatient setting, or, it could be with inpatient physicians as well. And when I kind of talk about this with many people, usually people say, I like this doctor the most, and I want to talk to him or her. So hopefully that will lead to more conversations and patients know what to ask. which will hopefully lead to ultimately to ideal end of life care. And this is what I'm trying to accomplish in my research. And if you could do the same thing in inpatient settings, you hopefully will see that this could be very helpful for patients. So initially, I developed this prototype, and this is a scripted text intervention where the left side is the original alcohol dependence script or motivational interviewing. And it kind of goes through the pros and cons and elicit patients' perspective and things like that. And I changed all the wording for patients with serious illness. And I sort of iteratively developed that and refined that using patients and clinician feedback. And that's the basis of my intervention. So far, I've sort of showed that this can be developed from existing evidence-based intervention in the context of serious illness. And then this intervention can be delivered with high intervention fidelity on clinicians who are trained in this intervention. And I've also shown that this can improve patient self-reported ACP engagement. So how much they are taking actions and beliefs about how ready they are to have these advanced care planning conversations. And also, a lot of nurses who are observing my studies thought that they wanted to do them as well. And certainly it's not for everyone, but at least half of them thought they're somewhat comfortable about doing these type of conversations themselves. And majority of them recommended that specialty trained nurse model, like the SANE nurse, the sexual assault nurse, or the IV nurse. Those models could make it more feasible in acute care settings. So this is so far what I've been doing for my research. And this script about motivational interviewing and what we do is all published. And I hope you might be able to use that in your clinical practice when you see patients in inpatient settings, because you'll see that patients would really appreciate that. Because patients say things like, it's really comforting and really appreciate to get to know where I stand, because most patients don't really ask them about their lives and how the disease is really affecting them. And some people have said things like, nobody had ever asked me these things before. And I'm sure you've ran into these type of situations in inpatient settings when you meet patients with serious life-limiting illness. And when you do, some patients are clearly more motivated and want to really learn more about how to take control of their care. And they say things like, what else should I think about? Like, this has never been discussed with any of my physicians. And what do I do next? And, these are also sentinel moments in their lives. And some people start to articulate, and you'd be surprised how much they would share with you, even though you have never met them before. Some people have told us that, I've thought more about this and rethought my life, and I really think that I should tell someone that I really love, or something like that. Basically to show how comfortable they are and how they are willing to sort of share all these personal values and preferences in the face of serious illness getting worse. So I encourage you to kind of take this type of approach and explore patients' values and preferences as they get sicker in inpatient settings. So just to explain where I am in this type of research, this is a model called orbit model, where it explains development of behavioral interventions from discovery to phase 4 effectiveness. And this is very similar to like a drug development or any clinical development. There is this clinical question, and you develop this phase 1 studies to define and refine. And then you do preliminary studies in phase 2, and you get the efficacy in phase 3 and effectiveness in phase 4. And basically, I'm doing the same thing. What's different about this for my behavioral intervention to change patients' behavior is that there's an iterative going back and forth between phases, like phase 1 and phase 2, whenever we learn new information about patients and how this intervention may help them. And so far, what I'm doing is that I started this project with a small funding from Emergency Medicine Foundation. And I sort of developed this more for an acceptability and patient-reported outcomes collection. And then I realized there are more problems like coordination with primary outpatient clinicians, patients with dementia, and clinician time. And I'm sort of taking this a different approach and using a nurse-based intervention model with Cambria Foundation help. And then I'm on my K award to try to establish the preliminary efficacy of this intervention. So, and hope for larger trials in the future. So that's kind of what I'm doing in my research. And I hope I'm going to share the script with everyone. And I hope that you can kind of find some parts of that helpful in your clinical practice as well. And I'm going to switch gears a little bit and talk a little bit about how to lead code status conversations. And this is more of a clinically oriented topic. And I think that some physicians may find this helpful in your acute care in the hospital. So I've had these patients who are coming into the emergency department with metastatic solid tumor cancer and hypoxic respiratory failure. And when I was in training, my attending or senior resident always said, go ask what they want, like they want everything done. And afterwards, because I was a medicine resident too, I switched services to the medicine service and realized that some of these patients are still there on the floor. And that's when I realized some families have told me, like, you would have never wanted this. Like, how could this have happened? So I realized that there's a lot of communication, miscommunication that can happen in these critical moments in crisis communication. And I hope to try to clarify that using best practices. So emotions can really affect decision-making in these times when people are super sick. And both your emotions as clinicians, as well as patients and families' emotions. And we need to sort of tackle that head on in order to make the best decision possible. And there's this thing called cognitive emotional decision-making theory, where really like the emotion can totally affect how you're going to make this decision. And cognitive sort of decision-making is just not possible when emotions are really high. So in that moment, when emotions are really high, and let's say your loved one is really sick, a clinician coming to you and asking you, does your father want to be intubated or put on a breathing machine, is really not going to elicit the answer that they would have answered if the situations were different. And you might be thinking, well, shouldn't this have happened before? Like, shouldn't someone else be doing this before patient got this sick? And this often happens in emergency department as well as rapid responses on the floor. Like, how could this have not been discussed before with this patient who is really ill? And sure, the reality is, yes, that would be ideal. And sometimes it is, and it's great. However, most times, we know that majority of patients who are older coming into the emergency department don't have advanced directives. And we also know that only 37% of seriously ill older adults have had these conversations with their physicians. And if they did, on average, 33 days before they die. So this is the current clinical climate that we're faced with. And that's why you see these things in your clinical life. Well, we need to still make this better. And of course, there's a lot you can do to make it better before patients get critically ill, but we do have to take care of patients who are critically ill now. And I'm hoping to provide a framework so that you can refer back to it. So in the context of intubation alone, which is often this really large decision point between what happens to the patients when they're critically ill, well, ED intubation is already a really bad news for older adults. And this picture is trying to explain that. The red proportions are folks who will die after their ED intubation. And yellow are folks who will survive and be discharged to places other than home. And blue are folks who would survive and go home. And as you can see from left to right, they're going in increasing age. Well, there are many other predictors, but definitely age has something to do with the chance of someone being going home. So if you're 90 and above, more than about half of them will die in a hospital, and only 14% would actually go home if they are lucky enough to survive. And overall, it's about 35% in-hospital mortality when they're intubated. So when they're intubated, or when they're about to be intubated in the emergency department, or if they are about to be intubated on the hospital floor, this is what older adults are looking at right now. So it is already a pretty bad news. And when you look at the long-term prognosis of these folks, this is the same depiction on the left, and 75 years old or older. And the red are folks who die in a hospital. So we will just exclude those. And just thinking about people who go to nursing homes, LTACs, home care, and hospice, when you plot them out over time, after they survive, this is what they look like. And as you can see, overall, it's about 32% alive at 1 year. So even if they survive, most folks are not going to go home. And if they're going to go to other locations, many of them will die over the next year or two. So there's no way for patients and families to really understand this, I think, when they're about to make this decision of intubate or not to intubate. And it's kind of on us, the clinicians, to try to get to this decision-making with them. Now, we also know that the function is a really important factor for older adults. And after critical illness, the left is the pre-ICU functional trajectory, and the right is the post-ICU functional trajectory. So what this is showing us is that, for example, if patients had moderate disability to begin with, they only have about 32% to maintain that function if they survive ICU. So what I'm trying to get at is the function is really important for older adults, and we know that they're going to decline if we are in this decision-making about intubation. And are they okay with that? So, some older adults would advocate that if you survey hospitalized older adults, they consider some states worse than dying. And for example, 50% would feel that not being able to get out of bed is really worse than dying, or they'd rather die. So there are many things like this. Like, for example, another one would be, older adults would trade 1 year of time to avoid dying in ICU. And it's about 87% of them would say so. And when you look at these research, you can tell that older adults likely value quality of life and function more than just quantity of life. And there's this discrepancy between what they're getting right now and what we can potentially offer. So talking about these code status decisions when people are acutely ill is not just these soft skills where some doctors are just better or nicer. And it's really an effective communication skill would actually help in these situations. And that's what I'm hoping to go over today. So we have all these checklists and different sort of algorithm in other things that we do in clinical life, like intubation or CPR or whatever it is. And my sort of suggestion is that, we never really learned it from anybody other than your attendings. And sometimes we learn other folks say like these, descriptive manners, or you may have seen other folks do like, do you want A or B type of manner, or some people are like more spiritual, or some people are more into statistics. And these are all different ways in which I have personally learned how to do these conversations. And I'm not sure if they are effective. And that's why I propose to do these checklists, just like we do in all the other clinical things. So I made these demonstration videos and different steps to take in order to try to get to this decision-making in this crisis communication. So I'm just going to go through it one by one. And the hope is we want to make a recommendation based on patients' predicted quality of life. So what that means is that in scenario one, if you can imagine, y-axis is patient's functional status and x-axis is patient's time. Well, there's this baseline function of the patient. And then this could be the minimum quality of life acceptable to patients. Well, you already know that after you intubate them or do something invasive, their function will go down. So I'm projecting that their function would go down. And if they're lucky enough to survive, they would be probably around there. And this is really a clinical judgment based on all the things that you might know in your head about prognosis. And at this time, this makes sense. This is likely life that's better and good enough for this patient. So you would recommend for intubation or whatever the procedure that you might be facing. On the other hand, the same scenario, if the baseline function is here and the minimum quality of life is here for the patient, which you have to elicit from the patient, and afterwards, in the best possible scenario, the post-critical illness function is here below the quality of life for that person, we would not recommend intubation or whatever the procedure is. So that's what I'm trying to get at with this conversation guide, to sort of systematically get to all these points so that you can help make decisions for the patients. So the goal is really to identify patients who would consider the best case scenario worse than death. And to do that, one, you have to sort of establish the crisis and say, hey, I wish I met you in different situations. Your loved one is very sick and we'll have to make a decision quickly. And then find out what they know. What have you heard about what happened today? And break the bad news. Well, there's some serious news. Would it be okay to share? And you deliver a headline that's clear and jargon free. Well, your loved one is not breathing well, and I'm worried that he may die. And you try to align your therapeutic intentions by explicitly stating, we will work together to decide on what's best, what he would really want in this situation. And then we explore their baseline function and values, because if you don't know the baseline function, you can't predict the post-critical illness function. And then also explore their values, like what are the abilities that are critical to live? What's the minimum quality of life? Blah, blah, blah. And then we summarize to demonstrate and show your work of what you found out about the patient and their values and preferences, and see if that was correct to confirm with the surrogate. And then you make a recommendation. Well, in this situation, I would recommend intensive treatment, because no matter what, you're going to do intensive treatment, focusing on either comfort or life prolonging measures or whatever it is. And then you can focus on what you will do and what you will not do in this recommendation, and see if the surrogate would agree to this. So these are the steps that we would sort of advocate you try, and try to see if you can make the decision together with the patient or the surrogate. So the questions to elicit patient values, which I find most emergency physicians don't do this. So I wonder if most medicine physicians do these too. But if you could figure out what their values are by asking things like, how much more would he be willing to go through for possibility of more time? Because there's really only a possibility of time. And what abilities are so important to him or her that he would not consider life living? What states could be worse than death? And some of the words that many palliative care and geriatric folks know to use are these words to respond to emotions, like naming, understanding, respecting, supporting, and exploring. These are things that sort of like we do as clinicians all the time without recognizing them. And knowing these terms and associating specific terms with exactly what you're saying actually helps you sort of get better at these skills, as well as help you sort of teach that to your colleagues when you're working with a medical student or residents. So many common words that palliative care clinicians say are things like, I wish things were different, and I worried that this means that he could potentially die, and sort of using the reflective listening skills, like what I heard you say is this, this, and that. and always ask for permission before you speak. Like, would it be okay if I talk more about this or ask you more about this? Which gives patients or surrogate a little bit more leeway in thinking about this conversation, because they're inherently in a position of no power, and you're just trying to give them a little more power back to have sort of collaborative conversations. And whenever I get stuck in these conversations when I don't really understand what's going on, it's always helpful to ask these phrases like, help me understand what's going through your head, or tell me more about what you mean when you say. And so these things, what they do is that you'll notice when you record these conversations that you're doing by yourself, because I do these for my research. Most clinicians talk more than patients or surrogates. And what these things do, by asking surrogates or patients to explain what's going through their mind, it allows an opportunity for patients or surrogates to sort of express themselves, which in turn brings down the anxiety or emotion that they may be experiencing. So these are the reasons why palliative care clinicians say these, and also to learn more about patients' values. And let's see, my slide froze. Sorry. There we go. So how do you catch yourself if you are potentially could be doing better? Is one, if you are catching yourself saying the possibility of survival or chances of survival, you're probably leading to a sort of wrong path. Sometimes not, but probably a lot of times. And if you are using terms to explain about procedures, well, this is important if you are doing like a shoulder reduction, but for these life-saving measures, you're probably, again, leading to a different path. And then if you're saying things like, I want to make sure you understand, are you sure you want this? Well, I know that that's how I feel in my head when I'm talking to these patients. But that's probably leading to a wrong path too, that you're trying to get a commitment from them. And what I'm trying to get at is this is really not about informed consent in these conversations. It's really mostly about navigating emotions so that you can help make the decisions with reduced emotions together, not just asking them to choose, because it's irresponsible for clinicians to make surrogates or patients choose in these tough situations when they can't really understand all the things that you understand. And when we're not sure, it's always a good practice to set up for time-limited trial. So what that means is that you say things like, hey, so, it sounds like you can't really make this decision right now and you need more time. Well, then we would try a course of intubation and see how he does in the next 24 to 48 hours. And, at that time, please think through what's been going on and expect another conversation to happen so that we can decide whether this is really working for him or not. So saying things like that is called time-limited trial. It helps the next clinician talk to these patients and surrogates, and it has shown to sort of reduce ICU treatment that prolongs suffering without benefit. So try doing these if you're not sure whether you've really gotten the right answers from the patients or surrogate. And my take-home points are that acute care visits are really sentinel moments for seriously ill older adults. And also, whenever you see patients with serious illness on the ward or emergency department, please start or revisit serious illness conversations that they've had, if they had them already, because these are times when their lives are rapidly changing, as you know. And, this is just part of our jobs. Clinicians must really share the burden of difficult decision-making in crisis communication with the patients and surrogate. it's irresponsible for us to ask them to understand everything that we understand in our head and make a rational decision when they are super sick. And we just have to, do our best with clinical uncertainty and try to take that burden with them, with us, so that we can do this in a shared decision-making fashion. So that's all I have, actually. And I would love to hear what people thought. And I'm happy to answer questions too.
Thank you for that. Maybe we'll open the floor to questions. Either people can unmute themselves or type.
And I wasn't paying attention to the chat, but was there anything on the chat or no?
No, nothing yet. So maybe while we're waiting for people to ask questions, I wanted to sort of take what I learned in the sort of second half of the presentation and reflect back on what you talked about in the first half. And maybe you could sort of summarize for me in that, acute care setting, when we see that there's this, the importance of having these conversations, is it following that same script that you highlighted in the second half, or are there sort of specific skills that you feel like are key in the processes that you outlined, unfortunately in sort of small print that I couldn't totally follow, in the first half that we need to think about when we're asking those questions? Sorry if that's.
Thank you. So they are basically the same. One, they're both to elicit patients' perspective as well as their values and preferences. The only difference is that in moment when they're about to be intubated or when they get real sick, we have to make a decision. So we have to come with hurried, urgent decisions together. That's mainly the main difference. And eliciting patients' values and preferences, they're mostly the same. So trying to understand how they have been living with their illness and what sort of worries that they may have had, what hopes that they may have had, and how this illness is really affecting the patient as well as their caregivers or families. And definitely learning also about patients' functional status at that time is important too. And these are all the same components, how I see when patients are in acute care setting, but not hyperacutely ill where they have to go to the ICU, and then other hyperacute settings. So yes.
Got it. Thanks. Dr. Goldstein looks like he just unmuted, and then Dr. Berger will get to you after.
I did, Dr. Weissman. Thank you. Kai, it's so nice to see you.
Great to see you.
Really great talk. I'm wondering if you could link this a little bit. I mean, I thought your talk was great. I felt like there's a little undercurrent of the assumption is that patients haven't done anything or haven't had conversations before this critical moment. But we know that some have. And I'm wondering if you could talk some about how in your work, how you think about and link your work to things like Rebecca Sidore's preparedness planning and prepare, and how much of it is we've never talked about this versus actually we talked about this a lot, but now I'm in this situation and things are very different. And Terry Freed wrote about this years ago, which is this idea of that which seems intolerable suddenly becomes tolerable. And now what you're talking about is, you're in a new state. I have some new information for you. And sometimes folks have to rethink what they've thought before. So I'm just wondering how you fit that into the rubric of some of your work.
Yes, thank you for asking. So I do agree that the proportion of patients who have sort of been exposed to this is fortunately increasing a little bit. And still at the same time in my current practice, it's mostly nobody. Actually, when I've enrolled for my study at least 80 patients in the last year or so, pretty much nobody has had these conversations either documented or have even thought about. And and I know that I'm sure some folks here think more about is advanced care planning really worth doing? Because we have seen some leaders in palliative care thought through this as well, based on our current evidence. And I think that proportion of the people who are thinking about this are increasing. Is it the right proportion of people who are thinking about this increasing or not is a really tough question. And I think what I mean by that is patients who are getting sicker with serious illness. I think there's really value in thinking through these for those folks, not for patients who are just arriving for the first, Medicare visit. So I think the proportion of people are increasing. Still, we don't have enough patients with serious illness thinking through these. And I think we still have a lot of work to do in that area.
Thanks. Dr. Berger.
Thank you for the great talk, Dr. Ouchi. I guess my question's a little bit of a corollary to what Dr. Goldstein mentioned. In all this models, it's very much about a patient who can make their own decision. How would you apply these models, though? Because many of our patients are either incapacitated or, sometimes these goals of care discussions occur emergently or peri-emergently after some emergent actions have happened. The literature that I've often seen, at least that's touted towards the general medical or general medicine services, is that a lot of families and people or other decision makers, they don't believe us, right? One, we're terrible at prognosticating, and two, they've often, as you talk about these, and Dr. Goldstein talked about these long-term struggles with illness have been back and forths, and they don't believe that this is the moment. How would you use these same techniques to approach a family member for a critically ill patient where you sort of, maybe it's the ICU, maybe it's not in the ICU, and you really see things heading like towards the end, or that this is going to be somebody who's not getting out of the hospital. They've been intubated in the ED, and that they fall into that red group. How do you approach the surrogates in these discussions using your model?
Thank you for that question, Dr. Berger. So I am currently working on, I realize this acute need for patients with cognitive impairment and dementia. That's one. I'm not going to talk about patients who have legal surrogates. I think that's a little different population. But patients who are suffering from cognitive impairment and dementia, and how would their caregivers approach this conversation with the clinician is a really important topic, because this is going to increase as well as our society ages. And I've been sort of playing around with different approaches to capture the inputs from both patients and the caregivers together, and sort of respectively articulating which part of the value is really patients and which part of the value is really the surrogates, and having them sort of go back and forth. So that's kind of what I'm doing in my current studies right now. And I completely agree with you. It's so important to sort of try to articulate what is the value of the patient and what is the value of the surrogate, and help them see both sides of things is so important. And as Dr. Goldstein also mentioned, we think that patients' sort of values and preferences usually don't change as they get sicker, but it kind of depends on how long it takes for them to get sicker. And if they get sicker slowly, things do change over time. And I kind of think about this, well, I'm mostly thinking about it from my own personal experience. But my dad became real ill, and actually he would never consider the type of life that he's living now be acceptable to him. And yet, it just happened in a fashion where there was no time to sort of address that. And, in the end, we have to also distinguish whose suffering is this that we're trying to alleviate. Is it the patient or the caregivers, the surrogates? And I think, that's also an important point to articulate as well. Sometimes patients may be in a horrible clinical state, yet they may not be suffering too much. And I think that's also another important point to articulate in these conversations together with the caregivers or surrogates. But I don't have a great answer. I'm just articulating that this is an important point. Yes.
Great. Any other questions out there?
Yeah, I had a quick question. This is Chris Wajal, palliative care physician. I'm wondering. Thank you for the great talk. I'm always struck by how hard it is in the emergency department setting or on the floors when something acute is happening, because you showed some data about sort of broad strokes of prognostic information, prognostic data, and by age group and functional status after critical illness. But as we know, it's so heterogeneous, people's clinical situation. And I'm just wondering what recommendations you have for the sort of rapid information finding that you might have to do in such a situation, because so many of our conversations are really driven by trajectory and what to expect if we're going to formulate a good, scenario planning.
Right. I find it easier to sort of ask and explore the patient's functional status and their quality of life that's acceptable to them, rather than like probability of survival after intubation. I think those are just general numbers, and as you articulated, it really doesn't apply to everyone in that particular age group and particular comorbidities. And I think that's why it's too hard for patients or surrogates to really fully grasp this, because it's hard for us. And when it comes to sort of functional status that's like good enough for the patient as well as the quality of life, I think patients can sort of articulate that. And that is kind of qualitative. It's not like how many steps can you take? It's kind of qualitative. And we just have to make the best judgment possible to try to see if that's even possible with whatever the intervention or crisis that you might be facing. So I think what I would say is that we should try to articulate the qualitative sort of description of the function and quality of life that patient would be willing to live for, and strive to sort of match that to our understanding of prognosis and statistics before we try to approach the patients and surrogates.
Thank you.
Great. Time for one last question, if there's one out there. All right. Hearing nothing, well, thank you, Dr. Ouchi, for joining us today and for this fascinating talk. And thank you, everybody else, for joining us. Have a great day.
Thank you so much for having me, and really great to see some of you.